Top Med Talk.
Hello and welcome to Top Med Talk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine annual scientific meeting in Cairns in beautiful far north Queensland in Australia. We've made 2 great podcasts already and we've got about a dozen more to go. It's going to be a big couple of days, Andy.
It certainly is. It's going to be a tiring couple of days too, isn't it? But as always, we really need to thank Solventum Australia, who have sponsored Top Med Talk Down Under here this year. And they really help make this podcast free and accessible and open access to everybody in the world. So thank you, Solventum.
Excellent. And they make products related to hypothermia. And so we've got a great guest here to talk about that issue with us, Holly Tonkin. Hi, Holly.
Hi, thanks for having me.
Hi, Holly.
Can you tell us a little bit about yourself?
Yes, so I'm currently an anaesthetic registrar at Royal North Shore Hospital. Last year I was an anaesthetic registrar at Manning Base Hospital, which is a regional centre in New South Wales, about 4 hours north. And that's where I undertook a prospective audit on hypothermia.
Fantastic. So why did you decide to study hypothermia?
So I think hypothermia is a very prevalent and very common. And essentially we have quite high rates. Various studies showed up to 70% in non-cardiac patients. So we definitely knew that there's something that we wanted to investigate. But the issue is, I suppose, is we needed to do something prospective because we didn't feel like the data was there retrospectively. So what we did is I spoke with my supervisor of training and we thought about how we can accomplish this. And we knew that Solventum were running these normothermic assessment programs throughout Australia at different other hospitals. So we got in touch with them and they were able to help set up this prospective audit, which basically what we looked at was we were able to calculate our baseline hypothermia rate. They provided us with a forehead sensor that was continuously monitoring temperature, preoperatively, intraoperatively and postoperatively. And we found that our hypothermic rates were 67% at baseline.
And which patients were these in, sorry, Holly?
These were elective surgical patients that were lasting 30 minutes or more. And these were general surgery, gynecological, general surgery and orthopaedic patients, adult patients. So then we thought, well, we want to do something about this. And so that's how we came about this quality improvement project, where we took warming gowns, which is essentially a full-length gown that patients can wear in the pre-op chairs and then can wear the same gown intraoperatively and postoperatively. And we commenced pre-warming 10 minutes prior to induction. And we found that the incidence of hypothermia decreased to 27%, which was 60% relative reduction rate in hypothermia by a very simple move of just pre-warming these patients.
And again, for the benefits of our listeners at home, how were you defining hypothermia in your project?
Yeah, so we defined it as a core temperature of less than 36 degrees. And we had these temperature sensors using zero heat flux technology, which were on their forehead and were able to basically tell us if the patients were hypothermic.
Fantastic. And what sort of time period with this project taking over? Is it months and months and months? So how quickly did it take to get the data?
So we did 60 patients and we ran that over a 2 to 3 week period in our theatres. But a lot of it was the setup prior to that. And I really have to thank the amazing staff at Manning Base Hospital. We worked really closely with the clinical nurse educator who helped help us educate the staff about the importance of avoiding hypothermia. And it was really a big team effort to do this. And we found that the results were quite clear by the end of it, and definitely something that we wanted to address.
So hypothermia has been recognised as a complication of anaesthesia for 35 years, I think, and forced air warming devices were developed and widely used for about the last 30 years. So what was the pre-existing practice at the hospital during the baseline period with respect to warming the patients?
Yeah, so our baseline practice was patients who were having operations for greater than 30 minutes were having intraoperative warming, so no pre-warming. And then we were using temperature monitoring intraoperatively, and then they would have just one monitor of their temperature in the pre-op bay. That was what we were doing at baseline. Yeah.
And were you using forced air warming blankets?
Yeah, we were using forced air warming blankets.
Yeah, terrific.
And so I was going to ask the same question, but it was the same blankets intraoperatively in both pre and post, or
What we
did you
did-
change the type as well?
Yeah, we
post?
changed the type, and the main reason for that is because we wanted to introduce pre-warming. And at Manning Base Hospital, our preoperative elective patients, they sit in a chair, so
Right.
we can't use the traditional sort of forced air warming. So we use these gowns instead. And we basically also found that if we just had the one gown that they could follow throughout the intraoperative and post-operative course, it would reduce things like multiple blankets, multiple other gowns, or having the forced air warmer in different stages. So overall using less equipment. And yeah.
And what did the patients think about it?
Well, we measured secondary outcomes, which included recovery discharge times and also patient comfort. And we found that there were no patients that were uncomfortable post-operatively, and so patient comfort overall was much higher. And we even found that sort of the following days in the ward, the patients were still wearing these gowns in their beds. So it was really successful, and the staff really found them easy to use as well. So overall it was, yeah.
So what's the warming device that's attached to the gown?
So it's still connected to the usual heating unit in the traditional sense, but the patients wear a gown, and it also has a little panel that they can control their own temperature as well while they're in the pre-op bay. But similar to a forced air warming.
And do they look like, Michelin men or something sitting there with the blown-up gown on?
It kind of looks very similar to the gowns that they would wear in the pre-op bay, but they
Yeah.
just have some hot air that goes underneath, so maybe a little bit blown up, but not too much.
So what did you think about doing research as a junior doctor?
Yes, this is my first project of something like this, an quality improvement project. I really, really enjoyed the experience, and it was basically I really liked working with the team and working with the nurses and the theatre staff to get it underway. I'm really lucky that we had Solventum support us and give us the more practical elements to doing this project. And I want to do some more, I think, inspired by the ASM as well.
And you're presenting this here today, this afternoon, aren't you, at the conference?
Yeah, I'm presenting in the trainee quality improvement prize session
Fantastic.
later.
Can you tell our listeners at home a bit about how you've got to this point? What did you have to do to be able to present it here actually at the meeting?
Yeah, so a few months ago I submitted an abstract with our results to the abstract submission, and it was accepted, and I put together a presentation, and I booked my flights, booked the...
So pretty straightforward
yeah,
and easy.
it's pretty straightforward, yeah.
We often find, or maybe this is just in the UK, but a lot of our residents and trainees are a bit reluctant to take that first step and give something like this a go, but hopefully what you're saying is it's very achievable, and you had a lot of fantastic help, which is great, but I think people will give people that help if they ask for it. But
Yeah,
what's it been
definitely.
like coming to the meeting?
It's been amazing. It's my first time here, and I'm feeling really inspired. The talks this morning have been amazing, and there's a lot of really good energy around, and I'm going to come every year.
So you're studying for your primary exam.
Yes.
And it's similar around the world. Early vocational trainees in anaesthesia study physiology and pharmacology and statistics and anatomy and stuff. It's hard work. It's probably the hardest exam you'll ever do, actually.
Yes.
But thermoregulation's a big part of that.
Yeah,
Yeah.
and as part of presenting the results back to the department, I did a bit of a talk and sort of educated the department about thermoregulation as part of that. And I think we all found it really helpful and really interesting.
So let's pretend it's your primary exam. What's the main cause of intraoperative hypothermia, and why does pre-warming help?
So I guess there's two things that I would put down to. The first would be our anaesthetic itself causes a vasodilator response, and then also heat loss. So we have a cold OR, we have a cold operating table. So there's lots of different forms of heat loss in the theatre. We know that, well, I guess the premise of pre-warming is the fact that if you pre-warm, the patient never gets cold. Once they're cold, you're sort of catching up on yourself. But pre-warming puts them in a place where they're never cold. And it avoids complications like surgical site infections and bleeding, coagulopathy, delayed emergence, and prolonged stays and recovery in hospital. So I guess there was another study that we, as a part of putting together this presentation, which found that the annual cost of hypothermia is about estimated to be $1.2 billion. So the simple interventions like pre-warming can be really helpful.
Yeah, the anaesthetics cause the brain to fail to thermoregulate, doesn't it?
Yep.
And so the patient vasodilates, and there's an internal rearrangement of body heat. so that their core temperature comes down. And what the suit will do, or the conventional Bair hugger, is to warm the peripheral compartment so that the gradient is less from the core to the periphery. And lots of people, people who have more adipose tissue, and also people taking blood pressure medication, they've pre-warmed themselves. And we're a bit pre-warmed here in Cairns,
Yes.
aren't we?
So we are. And
Yeah.
you've put the heat up very modestly, hiding the fact that your PhD was in hypothermia.
It was. I
So,
did a PhD or an MD by research with Dr. Daniel Sessler at UCSF in California. And so and when I was a primary examiner, I loved grilling the candidates about
good topic.
thermoregulation.
Well, you've handled Kate's grilling very well, Holly. But what's the next stages for you? What's this going to lead into, do you think?
I'm hoping to do more projects like this and do sort of, I guess, I'm really passionate about doing, simple quality improvement projects that can have a big impact, something like this, yeah.
Brilliant.
Terrific. Well, thank you very much, Holly. You can find TopMed Talk on our app and on the website, and also on social media. We're on Facebook, X, Blue Sky and YouTube. And if you go there, please subscribe and give us a big thumbs up. Finally, we'd like to thank our sponsors, BD, GE and Solventum, without whom we could not bring TopMed Talk down under free and open access to the world. Looking forward to talking to you next time, Andy.
Looking forward to it already, Kate.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.